Great, brilliant. Well, hello and welcome to the Stoke Mandeville Plastic Surgery webinar series. I'm James K.K. Chan.
And I'm Rebecca Shirley.
And I'm thrilled today, I'm very proud in fact, to welcome and introduce my good friend Mills Rughani. So I'm thrilled because Mills is such a good friend of mine. I've known him for maybe 14, 15 years now. We did our training, our plastic surgery training in Oxford together. Our kids have grown up together, and it's brilliant to see you again, Mills. I'm very proud as well because we started off our plastic surgery lives in Stoke Mandeville Hospital, where I'm working now, and Rebecca also, and you've gone on to bigger, better things, and you're going to share some of those with us. So that's really great to have you. I just wanted to say a few words about Mills, because Mills is not only a very talented surgeon, but he's an incredibly talented person in many other ways. He was hoping to be a professional cricketer, and he's also climbed Mount Kilimanjaro as an expedition doctor. And during his training in Oxford, he's always shown a particular interest in skin cancers. And he's done lots of research in Oxford as a research fellow, but also at the Ludwig Institute of Cancer. And towards the end of his training, he spent some time doing fellowships in Australia, first as a head and neck and microsurgery fellow at Princess Alexandra Hospital in Brisbane, and then the Melanoma Institute Australia in Sydney. And thereafter, he stayed in Australia to bring up his beautiful family. And now he works as a consultant plastic and reconstructive surgeon at the Royal Brisbane Hospital, where he was recently nominated as Consultant of the Year, and also was nominated, or I think you won the Clinical Educator of the Year in Queensland. So really great to have you, Mills. Really great to see you, and can't wait to hear your talk.
Great, thank you very much, James and Rebecca. It's a pleasure to be here, and hello everybody. And it's a very kind introduction, and I hope to do you proud. So as I say, I'm here to talk about the complex side of skin cancer reconstruction. My full name is Milap Rughani. This is probably a bit about everyone's career path, and I see the participants out there, and it's always difficult to know where everyone is in their careers. Some people maybe are still going through their training, some people have gone to that higher training, and some people are on their consultantship. And I always say this is a cliche, but it's not about that destination, it's about your whole journey towards it. And this was me in January 2017 with my world really, my wife and my two kids. I'd finished my training in Oxford and Stoke Mandeville, and I spent some time in Salisbury, and then I was ready to essentially flee to go and do my fellowships. My kids there were 6 months and 22 months, and a 24-hour plane journey is a hard thing to do at that stage. This is us sort of more recently. I've spent nearly 5 years now in Australia, 3 of which as a consultant. And I just wanted to perhaps share some of my experiences, my journey. I want this talk to be much about sharing some tips and tricks, because some of these cases are pretty complex, and they get, fairly large in scale. And I think only by sharing and by participating in these educational webinars can we hope to improve. So this was me. And I basically went from Oxford all the way. Actually, you fly from London Heathrow technically, but you go to Brisbane there, and there's Brisbane, the other side of the world. And so this is Queensland, really. Technically, that's the Gold Coast over there. But Queensland is voted the Sunshine State. It's meant to be sunny 300 days a year. Today, actually, it is raining. We're going through a storm because come summer. So it's quite nice, actually. It cools it down a bit. In terms of Queensland, there it is in Australia. You can see that basically, we're based in Brisbane, the capital city, and a lot of our healthcare tends to be very hub and spoke. Up here, maybe Cairns that you may go to, that's nearly a 16 to 18-hour drive. So it gives you a perspective on the reach of our patients. Some of them, if they go inland, are quite distant away from, formal healthcare facilities. Queensland, again, is the second largest state. And to put that into perspective, for the UK, you can fit the UK apparently 7 times into Queensland. So you can see obviously traveling up and down. It makes I remember journeys to, sort of commuting to Reading or Newbury or Banbury a bit more into perspective. This is an important graph. Have a look at that red arrow and red circle. Basically in Queensland, the number of non-melanoma skin cancers is double that of the national average. And I think Australia pretty much arguably has high average of skin cancers and non-melanoma skin cancers. Okay, so I always had this thing. I remember this from Dr. Sabapati, who asked me this. He asked me what your purpose is. And I remember everyone has to have a vision. Because we all have goals, whether we want to, you know, drive, I don't know, a nice car, go do some humanitarian work or something. But really, I always thought, what is your vision? And everyone should be thinking about this. Here's my sort of triad of it. Ultimately, I want to do my best for my patients. I definitely believe in a patient-centered care approach. I wanted to take on clinical challenges. I remember perhaps through training or through surgery, sometimes there were always times when you had to refer on, or some people didn't want to undertake that next step in terms of operation. And I certainly wanted my training and my practice to be able to encompass those. As opposed to everything else as well, I think research, teaching, teamwork is really important. And more so, we'll talk about some of the teamwork at the end. In addition, I think you should be innovating and researching, counting things, try and always make things better if you can. You can't do this job on your own. You have to build a team, and I'm lucky to have such a good team that we can all bring together. I always thought this, be kind to yourself, be kind to your patients, be honest with yourself, and be kind to your colleagues. Wherever you are in your training, if you want to get to the top of that mountain, you probably will. But the way in which you get there, I think, will reflect a lot. And Graham Perks had said this to me once as a bit of advice, that family is precious. And I think that's important to keep in perspective. What we do is great, and our jobs are really important, but we have another job as well. And that's really important to keep in mind. Now, I put this guy up because despite any big plan or any great idea we've got, you've always got to get ready for it, because everyone's got a great plan until they get punched in the face, really. And Mike Tyson popularized this this phrase. So always have a plan B, always get ready for a setback, and remember your vision, keep going with that. So this is perhaps a encompassing of skin cancer. There are, of course, you know, different avenues. I don't think this talk will allow us to go into each one. But you'll see here, probably more today, I will speak about SCCs, which is strange because during my training, melanoma was the big thing. And, you know, we all wanted a piece of it, and it was a very exciting thing. I think nowadays, for me, melanoma is less of a surgical, large-scale operation thing. Of course, the majority of melanomas can still be cured by surgery. But generally, that's a wide excision, a closure, plus or minus sentinel node. Rarely are we really going on to do formal nodal excisions, which I think is good for the patients. And of course, their survival has improved vastly due to all the therapies. So this is perhaps what I remember a bit from skin cancer. There's the Horton Hospital. I remember going there on nice little clinics. You know, you'd see a lovely local patient from Banbury. They'd have maybe a little BCC here. You'd talk to them for a while, go and have a cup of tea, talk to Mr. Cassell. And that was great. It was a good day. You got to do some minor ops in the afternoon. And it was good. And in terms of cricket, you'll notice I have a bit of a cricket interest. This was sort of, you know, your nice village cricket standard. It was pleasant. This is the Gabba on your left. And the Gabba is the test cricket ground in Brisbane. It's a beautiful venue, but it's usually the first place where a visiting English team comes for the Ashes. And it's a pretty hostile environment, okay? And as you can see, you start getting bouncers at your head. You've got to be ducking and diving, getting ready, because this is what's coming up for you, okay? These are the type of cancers that frequently we deal with. And I perhaps remember in England, you know, having a turban tumor here or there, but we pretty much see these quite frequently, and it becomes very much a normal kind of operation. So this is perhaps my outline. I wanted to show you some of my clinical cases and go through them. I want to try and emphasize some of the resection things we do. We, as plastic surgeons here, do all our removals. We're doing carotidectomies, maxillectomies, neck dissections, and the rebuilding. Sharing with you some of the tips and lessons I've learned, and also a bit about the surgical team and perhaps, you know, how to build as a better surgeon in terms of that perspective. Here's a little acknowledgement slide. These are some of the people I think throughout my training that influenced me, inspired me. You'll see some notable names from Stoke, Mandeville, Oxford here, some even the registrars who I worked with and James worked as well. And then you'll even see some people who aren't surgeons. Mark Middleton, for example, is a professor of oncology, but he was my research supervisor and taught me loads. When I came to Australia, you'll see Michael Waggles, Sam Yang, Gerard Bailey. Some of these guys really influenced me and supported me. And beyond that as well, I've kept in touch with a few previous fellows. Sharon Singh is in South Africa. Dan Sala is a friend of mine from med school who I've kept in touch with, and we've sort of followed paths and still share and keep in touch. And you can see that there's a broad influence, and a lot of up till now, my training, I think, had prepared me for what was about to come. So here's my few disclaimers. I, as you know, have an interest in complex cases. I'm keen to share and learn. This is just my view. There are many other ways, and that's the beauty of our profession. Certainly the variety of participants here, I'm not trying to teach you how to suck eggs. I'm sure everyone can master these things. This is just some tips. Ultimately, I can't cover everything. And so I think time will have to focus on some of the key cases. And of course, there are some graphic images. The patients have kindly consented to these, and I'd be grateful for their consent for that. So here's a bit about, I think, what we do. This is our normal plan. We're, of course, you know, the builders in that surgical world. And I think reviewing is really important. Someone once said, you know, a good result is humbled by a long-term review. Because if you review people for long enough, you'll start seeing recurrences and you'll start learning from your problems as well. This chap, poor chap, he lives far out in the countryside. You can see he's already had an ALT free flap, parotidectomy, neck dissection. Now he's basically going to lose his eye. He's got cancers everywhere. He's going to lose his ear, and he needs a further radical neck in an already radiotherapy field. So that again poses challenges and makes life a bit more tricky. So here, let's start at the top and see how we go. So this is a fairly standard scalp. We've all seen these. This is a sun-exposed site, high rates of scalp SCC. And if you had a small skin cancer there, you'd probably cut it out, stitch it up, put a little skin graft on it. However, this chap has had a previous SCC in 2018. He's had some radiotherapy already, and now he's got a recurrence. You can see all this area has been biopsied, and in case your screen doesn't show it, this is all a radiotherapy field as well. So it's a poorly differentiated SCC. You can see the PET scan showing the image, and he's right onto bone there as well. So pretty much the standard sort of treatment that we would do for this is a wide excision. I take a fairly wide margin. Normally you should, of course, take maybe 4-6 mils. Here in a recurrent field and poorly differentiated, we're taking at least 1 centimeter. And I think we'll come on to speak about that a bit more in terms of our margins. But you know, if we're going to put a flap on it, we need to cover this and get a clear tumor field. See here, that basically I usually leave a cuff of Gallia around the edges, just so that if you do put your flaps, grafts, or anything else on, there's always that border watershed area to leave it in perspective, and then you're straight hard onto bone. Okay, and then as you get down to bone, of course, you need to be peeling off that pericranium. I use a periosteal elevator, pretty much peeling off, and usually it's a nice plane that comes off. You can see just as I'm approaching now the epicenter there, you start to see tumor on the underside as well. And we'd already appreciated that. And this was a case that I'd also brought in my neurosurgery colleague. I'm quite happy to birth things on the outer table. I think when you start doing full thickness excisions or near sagittal sinuses, that's not when you want to be on your own. I've left the sound here so you can obviously appreciate. This is chamfering off the sides. I remember Mr. Budley used to teach me about chamfering off things. So I always think of him when I do this. And one of my colleagues is in there. You can obviously see the brain and dura exposed there. And this is sort of the region that we've drilled out here on the plan. It's pretty standard. It's a pretty standard reconstruction. We use a scalp transposition flap. You know, I love them. You can sort of do all sorts with them. I use a methyl methacrylate cranioplasty, a couple of plates. And that's him post-op, and that's him only about 4 to 5 weeks post-op there. They're ready to have his further radiotherapy if he needs it. So now we're going to take the rev counter up. That was like our sort of entry-level case that we have. Normally we do that, you know, in the morning, a couple of hours, and then carry on doing other stuff. My registrars will be all over that. So here is a case. This is a CT. Now you can see here, and I remember I was asking James this. I was like, can you see the little white bits at the top? And obviously you can see this tumor, but those little white bits are maggots, okay? And that makes it a bit more tricky because now you've got a infected full thickness wound, quite large wound that requires a wide excision. And there's no way you're going to get any local flap to cover this really. So this requires a free flap. You can see here again, I've got that sort of halo perimeter, keeping the galea, just so you've got, because when I put a muscle flap here, the edges are always prone to some dehiscence, but it's nice just to have that backup for you. And there's no need, oncologically, you're going at the epicenter of it and peeling it all off. Here's a standard LD. I usually do these either a bit sort of lazy lateral or fully lateral, but it allows a great muscle pedicle length and is useful. If you dissect it right up at the base, you can use your actual tendon of LD to cover up into the STAs, which is quite nice. It protects your pedicle, and a skin graft on top of that usually works well. Here's us all suturing together. Occupational health would be, you know, having nightmares. It's like a needle stick injury waiting to happen. But the important thing with this is if we're all suturing together, we can improve our time and reduce our time on table. Because ultimately, I think that benefits patients. And you'll see later on, I talk about these 1%. If you can improve certain elements of your operation, the whole thing can become better, smoother, more suitable. There he is post-op. You see his scars healed up. He's doing well and healed in terms of his flap. So now we're going to take it up a bit more as well. This poor chap, he's already had a massive scalp thing actually taken off because his HB dropped to 3.3 when he initially came. So he lost a lot of blood, but he presents with this big parotid mass. And you can see that quite clearly on the scans as well. He's got a neck mass, plus he's got a posterior neck BCC as well, which goes right down to his spine. So this requires a concurrent nodal dissection. So actually I started with this case first, just to even get access to the vessels. I tag a lot of my vessels. So I've tagged the facial nerve here, spinal accessory. I always get control of the IJV. And this is a complete 1 to 5 net dissection with a parotid. You can see here testing the nerves. I use a checkpoint stimulator, try and keep the nerves well hydrated so they don't dry out in that field. Marge there, and then the spinal accessories. So they're all working on table, and that's reassuring. That's our defect, again, similar style defect. And I use a harmonic here. I use it initially to dissect and harvest the LD flap. I quite like it. You've got to be careful, obviously, of it, but it allows you to get a nice sealed edge to the corner. So when you're going to inset a muscle flap, the energy is very much at that edge. It's not going down the pedicle. Here you can see then defect on the table, and you can see the full rotation of that. Initially, that little sort of dog ear they have settles down. You can see my access to the STs. Usually your artery is pretty good there. If anything, the veins are sometimes an issue. And if you dissect down a bit more, you can usually find a decent enough vein. There he is post-op. I think it's always important to show the donor site. Whatever we do, we should be mindful of our donor site morbidity. He even had a cervicofacial flap for that parotid. He's healed well there, healed well here. Maybe a bit tight there, but otherwise, actually, he's done pretty well. So now we're going to go even a bit more, all right? And when you have large-scale scalp defects and nodal pathology, you get stuff like this. So again, full thickness. You can see another mass there on the mastoid, and that's gone full thickness as well. So again, it requires a large-scale excision. And you can see my sort of markings there. That intervening skin bridge essentially has lymphatic spread, and you can't really leave that. If you're going to put a flap on it, you've got to cover that entire portion. So you can see the excision here. I usually tag, there's the STA that I tag. So when I do my harvesting of these big tumors, mindful they can lose a lot of blood. Okay, so I'm literally there all ready to go. Then we take the dressing off and then we go, because that thing needs to come off pretty quick and we need to get control. And the STA there, ultimately these tumors have been growing for a while and I sort of see them as being fed by the blood vessels. You can see the two areas that I've circled there that were full thickness. Of course, we went straight through on that side, and that requires a further drill out. So again, I got my neurosurgery colleagues and my ENT colleagues to come drill. This is the skull at the top. You can see here that there was probably signs of some involvement of dura. So we went into the frozen section of dura, and that was positive, and that's therefore we decided to take more dura. We also drilled out his mastoid as well with ENT. There he is post-op. He's had an LD, skin grafts healed quite well. He was frail. He's, taken some time to recover. But ultimately, this is a curative operation, and we went for it. So now we'll go a bit further down into your orbit. Since coming here, I'd never taken out an eye. I don't really remember doing that at all in sort of my training. I've taken out too many eyes for my liking since being a consultant. Depends on operation people either really like or don't like. I don't mind it. I find it quite interesting. And the hard thing is getting behind the globe. So I'll show you this guy. He's had a previous BCC. So basal cell carcinoma, as you know, they're not meant to do all this. He had it at his temple. He had a local flap he had done, previous radiotherapy as well, and did quite well. But obviously got a recurrence, and that has gone full thickness, starting to erode. His scans showed that it was going all the way back, and he basically had perineural disease going up his V1 into his orbit as well. So that requires an en-bloc dissection. Maybe the picture doesn't quite do it justice, but when you feel around this tumor, it's pretty much what I do. I can feel the induration and pretty much keep a thumb space around it, so you can get a good portion on that. Once you've made the decision to form a form of orbital disintegration, you don't want to be leaving these patients with further morbidity or further tumor and close margins. So you can see again that the eye is really not functioning well for him. He's better off without this. So that's our sort of resection. I usually go again hard onto frontal bone there around the periphery. You can see me approaching lateral orbit. And because here we did a joint case with one of my skull-based surgeons, we actually took off the frontal bar to gain access to the nerve as well. So there you can see our defect. Okay, there's the orbital contents. We've taken off the frontal bar plate. And you'll see this in a bit more detail. Going around, you can see right back into his orbital fissures. I usually put some anchoring sutures further up because you want to hold your flap reconstruction. Usually my go-to for this is an ALT. It's pretty standard flap for plastic surgeons. And I usually try and take it as a chimeric separate pedicle with a muscle component, because I sort of feed that in there to fill the dead space of the orbit and obviously the brain there, as you saw. Then the skin paddle, usually I try and keep thin as you can. You don't want it bulging out. That's him there. Initially, he's still a bit bulgy there, but he's healed up. His donor site's healed. He can go on to have further radiotherapy. Actually, people do quite well with one eye, I've realized. You can actually continue driving. They're not in pain. They're not troubled by things, and they're usually quite thankful for it. We'll go further down the face now. Again, mid-face maxillary reconstruction is not something that we used to do. It used to come up in our exam a lot. We didn't really do much of it. So this poor chap, you can see here, he's had a previous lip SCC, which was excised. He lived down in the countryside somewhere. And he developed a red spot area here, which his local doc said to him was probably just a little cyst or spot, sort of leave it be. He came to us, and you can see from his scans, that thing is a bit of an iceberg. It's got a lot more going on, and certainly goes deep. It abuts the maxilla, invades the maxilla, and he has signs of V2 nerve involvement as well, which requires a chase. So here's my sort of full thickness excision. I get down onto the bony margins and then make your bone cuts at the same time. Mindful it bleeds quite a bit there, so you've got to have some control over it. You can see our excision here, and if you look back at sort of Cordero's classification, it's probably up here with 3A. Kept the orbital contents, but he's got exposed maxillary, oral, and nasal cavities. He's obviously lost his bony contour. This is a different patient. I just wanted to show this little video just so you appreciate this in 3D more, because you can actually see right into it. And you can see what we're sort of dealing with. It's very much a 3D defect. For me, the goals are in this patient to obliterate that dead space, restore the support to the globe so that it doesn't toes down, separate off the nasal oral cavities so the patient can actually function well. They don't have nasal speech, they can eat, food doesn't go straight up. And ideally, if they can dental rehab afterwards, if they're suitable for that, then it's suitable. That first patient also required a neck dissection, so we did that anyway, and it's good for access. Again, I've tagged all my vessels, I pin them out on acetate, you can see the thing. Our standard ALT that we go to. This time I've tried to make it, again, having a few more components, paddles to it. And here you can see my sort of basic template. So I'll just talk you through this. This is my little sort of template here, obviously the thigh, knee there, hip up here. And you can see the areas that I've marked out. I want to sort of be the internal skin paddle, the outer portion. an area here that I've tried to de-epithelialize, because one thing that's quite hard with these free flaps is to rebuild that lip component. And therefore, I always usually use a lip switch flap, Abbé, Icelandic, whatever you want to call it. And I think that's a real like for like. If you can sort of, you know, in the era of transplant, this whole lip complex here, that is a real gem, because it's very hard to recreate it. You can see I tunnel my pedicle through here. I always use this little tube. The PA guys showed me that, and I find it hugely valuable. So there he is. This is you might have noticed all my little sort of sutures sticking out. And it's, for those maybe not doing as much head and neck surgery, it's a parachuting technique. Once you try and stitch this flap in, it's going to get a bit tricky, okay? But this is what I mean. So I have all my sutures ready on different clips. And ultimately, once you stitch that flap in, you want it to drop it in, because your hardest stitch is probably going to be the deep surface here of your oral cavity. And whether you do that, you know, first, last, whichever way is up to you. But usually I'd recommend you get those stitches in fairly big. You can see here as well, I put a little titanium orbital plate in that I contour on table just to support him. And I take the fascia lata and suspend it across from lateral zygoma across to his nasal spine as well, just to give him some support. I keep an NPA in there to divert it for a period as well. So there he is immediately post-op. Obviously, he's got pale skin. He's had from the thigh, and you can see the lip switch flap. There he is post-op. He's a bit crusty. I've always encouraged him to moisturize, but he's doing well. He's living. He's functioning, and you know, I think again a healed donor site, which is important. So I remember seeing this during lockdowns, because everyone's like, buy local, support your local shop, go out, eat local. And I say this as plastic surgeons today, it's not all about free flaps, because certainly in my training, that's all you wanted to do. You just wanted to get on there, do free flaps, get under the scope. But actually, the things perhaps that are sometimes the hardest operations are your local flaps, local regional flaps. And I think it's a real skill. So don't be shy of them, keep doing them, because otherwise, you know, you lose that skill. Here's a young chap. This tumor grew rapidly for a biopsy as SCC. Someone initially thought it was a KA and wanted to watch it convolute, but it hadn't. Again, I've taken a generous margin there, and it actually, when you feel it, it comes over that brow. This is basically a fairly standard ATT flap that we call, you know, it's basically an advancement flap. I undermine a fair bit here. Stitch it up. It's initially a bit tight, but if you use sort of consensual tension sutures, you can bring it in. And there he is post-op, post-raise, healed quite well. I'm encouraging him to tattoo an eyebrow so that he completes the look, but he's okay with it and he's quite happy. Again, like-for-like tissue is really important in the head and neck. Large tumor, this time I'm doing a wide excision and parotid with a cervical-facial flap. Again, pretty standard, and there's the cervical-facial flap that you sort of walk in and up. I take a bit more platysma with your flap. It always looks a bit, you know, tight at the end, and I trim that dog ear, and there he is post-op, post-raise. It's got full function of his nerve. He can walk around. Yes, he's lost some of the hair there, but actually he's doing really well. So let's focus a bit more on these SCCs, because that's pretty much what we're talking about. This is my sort of algorithm for looking at SCCs. In particular, I'll draw your attention to this bit. You can see the special sites, and by that I mean sometimes be careful with medial canthus, that sort of lateral nose, posterior auriculus, and obviously the scalp, because they can really, I feel, have had either multiple goes elsewhere, because people think it's a quick op and I'll just do it, but they can really sort of funnel down due to the, obviously, the embryonic origins of it. Recurrent incomplete lesions, they're always tricky. I've sometimes had people who've had 4 or 5 goes before they come to us. And obviously in immunocompromised patients, transplant patients, as we're getting more and more, we see them more, and they're obviously living longer, but they have worse disease. It's a fairly standard algorithm there. I think macroscopically large tumors, microscopically deep, poorly differentiated with PNI, perineural invasion are high risk and important to go through an MDT process as well. So this is our MDT here. I think it's really quite unique to Brisbane that I'd seen before, and I know it's been copied a fair bit in elsewhere in the world. But here our patients attend our clinic, and it's great. They get to see a variety of people, everyone from skull-based surgeons, social workers, dietitians, speech therapists, all come and see them. It's great because it provides a much more coordinated care. We get shared decision-making and proper planning. I showed you this, okay? So I like this. I'm just going to show you this. This is the corridor where all the rooms on the side are where the patients sit. And you can see all the people who come and go and see all our patients, okay? And if I draw your attention as well to this bit, I like this slide because it shows that everyone who's coming picks up a little piece of that puzzle. And slowly, of course, when you talk about it, you bring that together. And I think it's important to recognize that sometimes these patients may psychologically, socially, financially even not be ready for these big operations, and we need to support them in a much more wholesome way. There's Henry, our registrar, walking up, doing his good job. Okay. This is our MDT room, standard like many other rooms, I'm sure, across the world. A lot of people teams in nowadays, which I think has changed and done good. And again, I'm really lucky. The people in the room are expert surgeons, oncologists, radiation oncologists, radiologists who are just fantastic and they really help us. Before I used to cut a lot of tumours out, I didn't pay much attention to radiology. If I'm honest, during MDTs in Oxford, there's maybe a time to sort of semi-switch off or do something else. But now I'm like on it. The night before, I would go and see our very kind radiologists and actually look at all these scans. Because when you're going to cut something out, you pay much more attention to it. Okay, let's move a bit beyond the head, if we can. So this is the shoulder region. You can see here, we're up on the deltoid region. That tumor is a BCC. It's pretty stuck onto the deltoid. So there was a high risk that he was going to lose his deltoid and require a full reconstruction. Again, we take a fairly wide, broad excision of that. I've peeled it off, and actually I took sort of the one component of his deltoid, but with some further sections as well, I managed to get a margin clear. So basically, he just had an ALT. I've plumbed it up there onto his lateral thoracics that we had to go finding a bit. And there he is just post-op. Initially, you can see even signs of radiotherapy here, but he's had a good recon. He can fully abduct as well, which is important. I'll show you this picture. This is Portobanús harbour in Spain. I used to love going there. And basically, everyone lines their boats up. And it's usually, you know, everyone's looking around. It's this, even similar to maybe a doctor's car park. They're always like, who's got the biggest boat? Who's got this? And this talk is not about who's got the biggest tumor, because everyone's got those. Everyone can recall a story about it. I think it just gives you a perspective of these are frequent things. These are probably weekly, you know, maybe three to four a month that we'll get through some of these. Unfortunately, that's what we're seeing. Again, you can see this. So this is BCC on the shoulder, which has gone full thickness to bone. This is an SCC on his back as well, concurrently that he's got, which is going onto his spine. He's got this pattern here, which I was very suspicious for lymphatico venous infiltration as well. And really that whole area I felt needed to come off. So here he is, he's lateral this side, this is his head, back, hip. And you can see my markings that I've tried to take everything out. Ideally, I like taking stuff on block. So again, we're performing the excision here. We take it off, we've peeled it off, and we've nibbled away a fair bit of his spine of his scapula. I kindly got an orthopedic colleague of mine to come and put a fixation plate to fuse that shoulder of his. And this recon was just using the LD. We were already there, advance it up, cover it up, skin graft on top. And he did quite well. You know, he goes back to his town. He's quite happy. He's had radiotherapy, and he's pretty good at his function. So I've shown you all good cases, and people usually do, they pick their best, polish them up a bit before they present to an audience. But I like this quote, sometimes success is a lousy teacher. And if you keep on, anyone who's operated long enough will know that you don't always have these successes, and you will come across your complications and failures. And being a consultant, I think it's one of the beauties, because you really get to see and learn from some of those episodes. And so I say this, I embrace your failures, learn from them. I learned that when I do my research and science experiments. So this chap has got a fairly standard ulcerated SCC. He requires a wide excision and superficial parotid. However, he thought he would try and use a topical homeopathic non-evidence-based cream to try and cure him of cancer. It's like sort of, you know, anti-vaxxers and so forth that we have these difficult conversations with. And sometimes I usually try and respect the patient's decision. I want to go with them on it. But I do try and point out a few more facts nowadays, because this is what happens. 3 months later, that tumor's grown. He's got a full thickness facial nerve loss, and you can see it encompassing, eroding away. And now the stakes have gone up, partly due to misinformation. So here you can see on table again, I've taken off many eyes, ears. It's sort of Bill Coburn, one of our other colleagues, calls it Lopovsky. He's always wanted to take off an ear. And basically we go hard on here. This you see is my posterior approach. I do this a fair bit for those tumors where it's hard to approach the facial nerve anteriorly, so posteriorly. And you can usually find a good plane between your digastric SCM, but be very careful as soon as you come through that EAC, which is there, you will start to pretty much come across that nerve. And of course, he required a radical parotid. He's got a temporal bone here. I drilled off his zygoma. We peeled off and also drilled off his mandible, angle of mandible. T and J is gone. He's had a concurrent neck dissection as well. And you can see what we've done there. This is again, chimeric ALT flap. You can see I suspend it. So I use the muscle so it doesn't toes down. This chap also, we chased his facial nerve back to the second genu with my ENT colleagues, and that was all clear. He's had a lateral temporary tarsorrhaphy there as well. And there he is, free flap on, you know, it does the job, it does okay. However, post-op, things don't always quite go to plan. And he basically had an infection wound breakdown, for which I debrided. So you can see now, my flap, while it's pink, it's alive. It's got exposed mandible, exposed temporal fossa bone there. So here's a conundrum. What do you do? So James might help here. Is that right, James?
That's right. Here we go.
So this is for the audience. I want you to just have a look and pick a poll as to what you would do, because now you've got to do things. Okay, that's good, yeah. So that's good, I agree. So if we go back, you could, majority say we should basically do local regional flap. You're right, I think a scalp flap, cervical-facial flap, you can do. Remember, this is probably quite scarred tissue, and trying to get those also healed in time is tricky. And basically, I'll share mine. So that's what I did. I went and redebrided it. I took out my flap. It wasn't quite doing what I wanted to do. And I put a new free flap on. I used a VRAM that has a muscle component and a cutaneous component to plug all that, refresh that. Because basically I wanted to get this guy healed. And I thought by using a combination, you know, when you look back at that flap, photo and defect, you can use a bit of Scalp, you can use this. It never quite goes as far as you think. And it needs to be solid. You know, you don't want to sort of keep on half going and thinking, will this work, will this not? So these were my learning points. Someone said this to me, Michael Wagner's in fact said, take back as an opportunity to make it better. And I always think about that. So whenever you do go back, think of other things. What else can you make better? Own your problems. It's natural sometimes to be a bit shyer of these patients and their families if things don't go as planned, but try and get closer to them actually. Talk to them more, be honest, be open, always have your plans. Liaise with your colleagues. That operation, my good colleague Darryl Dunn came and helped me with that. So a consultant colleague is always good for a take back because it's never a nice experience. And the result is not having a perfectly healed flap. The result is that patient to heal, leave hospital, get radiotherapy, and you know, continue their life. So don't get sort of task focused. We can get really attached to our flaps because you raised it, you plumbed it in, and you know it's your baby. But actually, sometimes it's got to go. And I always think, yeah, don't settle if that's okay. So again, that's just my view. That's what I did. There are various ways. Here's a little graph that I just want to show you. And this is a sort of career path graph I saw. And it's going to lead us on to our teamwork bit. When you start and you finish your consultant training, you sort of think, great, I'm ready to hit the ground. And you basically, some people think, oh, I don't know, this is not for me. I'm out of here. I'll get you something else. Some people think I'll just happily keep on going and I'll just keep on applying the principles that I learned during my training. And this is what I saw that I hopefully is trying to aspire to or want to aspire to, but I'm still learning, is that you want to always keep on trying and not giving up. Have that growth mindset. If things don't go quite right, don't give up. You know, think about it, reflect, and then try and become that master. And I certainly learned that doing science experiments. So I showed this slide. In fact, when I was chatting to James, he had a young surgeon with him, and I showed him, obviously it's an F1 pit crew, and I said, if you're the surgeon, where are you here? And his colleague, I hope doesn't mind me saying, he was like, that's me, I'm Lewis Hamilton. I'm like, you know, of course, when we're surgeons, we want everyone to be around us. Fortunately, that's not quite how I think. I think this is the patient at the center, and we're all little parts, the cog of that wheel, whether it's surgery, anesthetics, the ward, ICU, you know, even the nursing rehabilitation. Unfortunately, in our, certainly in my experience, when we come to theatre environments or ward environments, our teams are constantly changing. You know, sometimes I may go through 3 sets of scrub teams in a day. And imagine if Lewis Hamilton has just, different people, new people coming that have to relearn each other. That would not work. So it's important to be mindful of that. And there's a few things I thought I'd share with you. I always start my team operations with a little brief. Sandra is our anaesthetist here, some of our nursing staff, registrar, we're all on first name basis. I tell them a bit about the patient, and I try and make it a very open approach and a proper plan. You can see my plan written up. I remember Matt Potter used to do this, and it was always good to see it. It reminds me of sort of an order of a service for a wedding. You know exactly what's coming up. And it's always nice because whenever you start a task, make a list so you can tick something off. Everyone here is on first name basis. There are no doctors, misters, dukes, lords, anything like that at all. I've got the anaesthetic team, nurses. So if you walk in the room, you put your name on the board and then you're part of it. Okay, even as a student, that doesn't trouble me at all. I usually have this. I try and have no hatred in the theatre, which is a cheesy acronym, but this is what it means. So I don't really want people being hungry, angry, tired, rushing around, overly emotional and dehydrated. And, sometimes in surgical training, and in all our training, it was a sign of weakness if you wanted to go to the bathroom or you wanted to eat something. But, I don't enjoy that. I try and dovetail our teams. So my reg will go for a bite, then I'll finish something off and someone else, because you've got to perform at a high level and you can't if you're any of those. This is a little video clip, and I did this just so we show how it's set up. This is patients having a head and neck operation, having a free flap from the forearm. This is just even, the operation even started, and anesthetics, two teams, trying to just sort of get a gist on what goes on, the equipment, the setup. If you can really keep on hammering and nail these points, you can improve and of course reduce time for the patient. You don't then need to expose further donor sites. If you can harvest together in terms of your resection and recons, that also helps as well. So I always think it's interesting to watch and learn from those. This is my sort of, I have an interest maybe in human factors, and aviation does it very well. Surgery is embracing it. I have this little checklist that usually goes in a folder on the wall, and concentrate on the white bits here. Okay, don't try and read the two little things, but ultimately it gives someone who's never seen that operation before what's about to happen. So we're going to prepare the flap. Flap comes off, and in that crucial time, of course, that's an important period. Then actually when the flap's back on, we can reassess it. I usually go have a cup of tea. As soon as I finish my micro, I have a cup of tea. Because I sort of want to, number one, recharge, take a fresh perspective. And when you come back, I think inset is key. And actually, you don't want to kind of quickly inset and get the patient off, because some of these things, it's that one opportunity to do it right and do some adjunct procedures for me. I'll show you this if you can hear. Usually my theatres, the lights change, the lights go dim, the micro, the music changes. I have a playlist on Apple as well that sort of sits to each bit. And I think it's important. I try and watch and rewind my microscope operating as well. Alex Rampton showed me that. And I always sit down and review it. Even if I'm training one of the regs or fellows, we'll watch it together. This was popularized by British cycling team, the Sky team, and it's really 1%. And I think if you can keep on just improving that 1%, keep on learning, keep on reflecting, over time you should improve. Whereas if you get a bit comfortable and you don't mind too much, and slowly things will decline over time. So keep that in mind in all sorts of practice. This is me at the end of ICU. We always try and do a handover together if we can with all the teams. So you can hand the patient over. You can see pre and post-COVID times here as well. And again, seeing the patient, I'm really lucky to get an OT, a physio, a nurse, junior doctor, my reg with me. I think that holistic ward round, being on the ward round, looking at each problem is really important. Without any of these people, none of this would be possible. So this is the team that I have who are brilliant. The ward nurses, our admin staff here, physios. This was our fellow, he was leaving. We don't normally drink champagne, but we had a little tea party for him with all our theatre nurses, regs. And again, I have not been doing this in Brisbane for that long. There have been people here who have been sort of leading the way. Del Hinckley in particular probably deserves mention there. And people like Daryl and Kieran. Daryl in particular is a familiar face from Oxford. And it's funny, we were registrars together for 6 months, actually in Stoke Mandeville. And now he's probably one of my best colleagues. We share a lot of cases, thoughts, problems, and it's really important to have him. So Daryl should have probably gone up massive letters in that acknowledgement slide, because he's really supported, and it's nice to have a colleague like that. Here is Bill Coburn. Bill is a senior surgeon in Brisbane, and he's been great. I operate with him once a month, and I save some big cases, so we try and do them together. And it's really helpful because he has some great pearls. He's seen it all before, and he's cool as a cucumber. So it's useful. One of the blessings I have is the people who train in the system here in Australia and Brisbane. I'm very lucky to have these regs and PHOs and SHOs who are fantastic. They work hard, they're skilled, and they're very supportive. And this is a little thing that I sort of do at the end of the operation. They all get a warm towel, hot blanket, and so everyone gets a warm feeling. So if you've stitched up a donor site, if you've held a retractor all day, if you've done microsurgery, you've done it, you still get that. And I think it's, you know, you can be at 9 p.m, 1 a.m, but it's important to acknowledge that. This is Tia, she's one of our coordinators. She's fantastic. She keeps me in check at work, and it's really great. Ultimately, this is why we do it. We do it for the patients. They are the bravest people of us all. They let us trust us with their bodies, and I'm always grateful in all of them. That, you know, getting over these operations is very hard, and to be with them on these journeys is very satisfying. So that's it really. These are my take-home messages. Have a vision, make a plan, get ready to get punched in the face, don't give up. Respect your patients, communicate with them, know your principles, recognize these troubled sites. Skin cancer is not all that simple. To be suspicious, always keep reviewing. Research or reflection is key to improving. And ultimately, teamwork, communication, I think, is everything. And without these guys in my world, it's been nothing. All right, thank you.
Thank you, Mills. That's great. And I think what stood out for me is just how you come across people in your training. Like, I remember working with you in those days, the Horton days, where it was small BCCs and local flaps, and just to see that journey that you've been on so far, a journey that's a long way in distance, but also just in terms of complexity of case. And a couple of people in the audience have just picked up, which I thought as well, is how do these cancers get so big? You seem to be treating really advanced level disease. What we'll do, we really like people in the audience to get involved and ask questions, and we'll invite you to come up onto the screen and ask Mills your question. But yeah, for me, it really just reminded me of how great a privilege it is to meet and work with so many different people that are all on their personal journeys, going in completely different directions. And you are obviously on a journey which has taken you a long way, and very excited to hear where you're going to continue going on that from there. James, would you like to say something?
Yeah, brilliant. I was totally blown away, Mills. And, you know, even though I've had a preview of your talk, I mean, you know, looking at those cases, mind-boggling. And I had mixed feelings, really, because, you know, whilst I'm really proud of what you're doing in the Royal Brisbane and so on, I'm slightly angry that they've taken both you, Daryl and you away from us. So anyway, look, I think I've got a million questions to ask you, but I think we'll give the audience a chance to put some questions directly to you, if you don't mind. So do you mind unsharing your screen?
Yeah, stop sharing. Yeah. Yeah.
And perhaps whilst people are thinking about questions to ask you, Rebecca, have you got anything to kickstart this session with?
Well, why skin cancer? Was that something that you always just had as a goal and a vision of something you wanted to do?
No, not really. I think we see a lot of it. I think plastic surgeons do a lot with skin cancer. It's our routine practice. I was lucky. I think certainly my research influenced me a bit. And once you sort of do research in something, you get a bit of a label with something. But I pursued it. And to be fair now, I'm fairly generous. I do a lot more head and neck, oral, cutaneous stuff, limb trauma. But the skin cancer, especially in Queensland, you can't get away from it. And you've got to be able to deal with all these perspectives.
Do you do the smaller things too? The little smaller flaps?
Yeah, I have a little locals list once a fortnight, month as well. I quite enjoy that. Sometimes they're much more tricky. Doing a BCC on a nose here, doing a little bilobe flap or a little one around the eye, you know, that's really important because that patient, their function, their scar, and of course, excision margins are really important to get right. So I take that just as seriously as I do a large scale operations.
Now on the BCC, going back to that case that you show with the orbital exenteration, and it was a horrendous BCC on the temple, and you said there was perineural invasion. How did you chase that down, and how did you then know whether you've got adequate resection before you went on to reconstruct it?
Yeah, that's fair. I should probably show the MRI. That has shown it better, because you can actually see the nodular cystic component of it. We see that quite a bit. And so when you've got the globe here and then the orbit, you've actually got to go all the way back. And so first to get around it and take obviously out the exenteration. That's why we did the flap on the frontal bone. Ryan Somerville is a colleague of mine, he's an ENT surgeon, special interest in skull base, and he helps me loads with these. And so we chase that back. He then drills out, gets his microscope as well. Obviously, you see he got a brain approach, and then he takes frozen sections from them as well. And once you
just to clarify, sorry, Mills, it was going down the front. Which nerve was it chasing?
Yeah,
down?
obviously opting over. There's V1. He had V1 spread as well. Yeah. So that's unfortunately quite common. That's why I said even the medial canthus tumors, sometimes they end up spreading up there. And you end up doing a fair bit of nerve chasing.
Right. And how often, because given the size of tumors you're encountering, I presume that it's not uncommon for you to not just get your skull-based surgeons, but even the oculoplastic surgeons dealing with tear ducts and the lacrimal system. And
sometimes that happens afterwards. So once I've done a recon, if they've still got drainage problems, we get a few nice colleagues to put a stent in, and that's useful. But usually everything around the eye, we do a fair bit of as well.
Can I ask, the question that we had the poll on, was that an easy decision for you to make, what reconstruction you went for?
No, I don't think they're any easy, because you're right, and the poll reflected it. You could just, put a couple of local flaps and get it done. The harder decision is to bin your flap, because that flap was pink, it was bleeding, but it just wasn't doing its job. And so that was hard, but I remember, I think I debrided it I saw him on the Thursday with it, debrided it on the Friday, and I redid it on the Monday. So we pretty much just went straight for it. And I spoke to Daryl over the weekend, and we both, and he kindly as well, helped me with that. And I think that was really useful. So no, it's never hard. Sorry, it's never easy. And I probably only lost two if you count that, 2 flaps in total. And it's never easy to make that decision. But I think, again, the result, getting that patient healed out of hospital, he healed so much better after that. We were able to, reset him. Going back into a neck, going back into vessels is not fun. And it's not nice doing that. So you've got to be ready to overcome those things.
Why Brisbane? How did you end up there, and why?
It's a good question. Obviously, I finished my training, and initially we were only going to come for 2 years. I was going to do a year in Brisbane, here in Sydney at the Melanoma Institute. My girls were little. We thought we'd go see the world. And then, things just happened, and we decided that probably just sort of for our kids' upbringing and a few other reasons, that we thought we would give them opportunities here, and Brisbane were kind enough to offer me a job.
And do you welcome a lot of visitors to your hospital? Is that something that
What do you mean?
So visiting surgeons, people who want to come and see what you do?
Yes, yeah, always happy to see. I would encourage that. We have a fair few fellows that come. Currently it's mainly from Australia, so a few people from Melbourne have come here, which has been nice. Again, just working with other doctors and sharing your practice is always good, and I think it just builds a better environment. But I'd always be keen, if anyone wants to come, you're welcome to.
Mills, we've got a question from Nick Brinkman, who says, thanks for a great presentation. Do you ever create an opening in your local or free flap if you position it over your external auditory canal?
Yeah, that's a good, so I think in a scalp flap, if you're putting something like that, and that depends on a few things. So if the ENT surgeons have kept the ear canal and ear drum, technically you want to preserve that ear canal so they can obviously hear. So I've done a few things. Previously, I've either used a supraclav, where I've pinned it right up against the EAC. So I've stented it, and I've used like a zero-form wick to stent open the EAC. Sometimes, once or twice, when you put a scalp trap, I basically used a punch biopsy, a big one, to stick straight through my flap. And actually it works okay. It's not a nice feeling. but it's a sort of local flap, and I hone in a fair bit on the vessel of my like transposition flap. So I'm okay with that. Yes, I think that's important. I think you have to make the call earlier whether they're keeping their hearing or not.
Right. Now, we've got a question from Walid Hamdoun. I hope I pronounced it right. And I'm going to try promoting him as panelist to see if he can ask you the question himself. Walid, are you there? Oh, he's gone. Oh, he's here. Great. Hi, Walid.
Hi, Walid.
Hello.
Oh. Okay, well, let me ask this question for you. Are the artificial skin substitutes, do they have a role in your reconstructive ladder?
Yeah, that's a big topic. Currently, not really. I think certain dermal substitutes are tricky. It depends what you're trying to remake. If you're trying to resurface things, actually, obviously, free flaps and free tissue transfers, superseded that. These big tumors obviously are infection prone, and the last thing I want is medpore or some cellular dermal matrix getting infected. Usually I don't really need it. I try and incorporate. That said, I do think there is a role for further 3D printing scaffolds that we can basically incorporate flaps around. And I've got a case of that coming up. So generally, I don't use it unless, I just worry about the risk of infection.
We have got some more questions here. I don't know whether Yegarimo Ido wants to come and answer the question, ask her question, or his, possibly.
Just promoted them. Okay, she's joining us. Hello, Yegarimo.
Yeah, hi.
Hello.
Hello.
Where you? What? Thanks for dialing in. Where are you dialing in from?
Ethiopia.
Sorry.
Ethiopia.
Yeah. Addis Ababa. Yeah. Yeah. I have attended part of your presentation, and I've seen the one with a very huge defect on the temple area that was covered with a free flap. What would be, in my center where I'm working, free flaps are not possible, but we get such huge defects. And what would be a good suggestion if you end up somewhere in Africa and are given such a patient?
Yeah. That's a good challenge. So, I mean, if we're talking about scalps and temple regions,
yeah, if you could also answer if the calvarium is involved, and if you had to remove, and what would be the immediate post-op management if you have bigger defects on the calvarium.
Yeah, sure. So scalp flaps are pretty much my go-to. The scalp has an amazing blood supply, and you can usually, use parts of the rest of the scalp, transpose it up. It just means then you've got to graft your donor sites, which are usually on the posterior, which I don't like doing because they lie on them, but that you can actually get a great way that way. Sometimes you can even use, you could use a temporal fascia flap, turn it over and graft on top of that if you really wanted to as well. Depends where and how big, of course. When they are massive, it's quite hard. I've seen a trapezius flap get up to the top of the scalp once, and that was fairly impressive. But you're right, if you're right on the vertex, usually then you've got local transpositions. If you're up here as well, you can use turnover ones. For the bone, I think you said, yes, I take, sometimes I either burr it, if it's got proper invasion on preoperative imaging then requires an excision that can either be outer table only or full thickness. I usually do that with a neurosurgeon. And we do the recons with methyl methacrylate on table. We basically mold it there. Because partly we're not sure about our size, we only judge it on site. We don't have the fortitude of that planning perspective if it's a set tumor as such. And of course, be careful of the exothermic reaction. Once I lay it in, and I take it out onto a plastic sheet, mold it, and then chamfer off the sides, put a couple of plates in. Post-op, most of my patients they wake up from anesthetic, they go to the ward, head up, neutral, mindful wherever your pedicle is, that they don't wear their glasses and compress it or lay on their side. Normal parameters, keeping them warm, wet and happy, usually what I say.
Have you ever had to use the old school delayed deltoid pectoral flap to get all the way up there?
I haven't gone all the way up there. I've used delta pectorals, sometimes for irradiated necks that you're doing as salvage cases. Not all the way up. No, I haven't had to do that.
We use delayed DP flap, but not. It doesn't really reach as high as to the temple, but it might reach up to the zygoma, or if we can bring it up to the upper portion of the ear pinna. But we still use a delayed DP flap, as well as he said, transposition of the scalp. And at times, if it is a very huge one, we end up using also radial forearm pedicle flap, keeping the arm up on the forehead for about 2 to 3 weeks, and then divide. Yeah, maybe you have forgotten all those things in your part of the world.
Yeah, that's impressive. And and sometimes as well, say if you've just got an exposed bit of bone there, again, you can just burr it sometimes and put a skin graft on it. And actually that works. It depends again if they need radiotherapy afterwards, how prone and how robust you want that recon to be. So that's always the risk or tricky.
Yeah. Thanks, Rughani, for coming on. We really appreciate your input.
Thank you.
Can I ask you, Mills, so over the last 5 years, are there things, you talked about free flaps and decision making, are there things you've changed your opinion on, or things you've definitely kind of moved away from, or opinions that have changed as you become more experienced?
Yeah, that's a good question. I think I've probably realized there's never an always, and there's always never. So, I haven't ruled things out. Try stuff. When you start, obviously, an ALT, an LD, gracilis, they sort of your workhorse ones, but then you sort of venture out a bit more, incorporate various bits of tissue, chimeric, bone, stuff that I've sort of really thought, initially I wouldn't have gone onto STs. I'd have thought that's a bit of a small vessel, it's a bit crazy, but actually once you dissect, you look at the flow, if it's good flow, it's fine. And you can do a neck dissection at the same time, as long as you're careful. I preserve a lot more. So I probably operate in certain areas a lot slower now, whereas other times I'm a lot quicker. That's probably fair, because I sort of know when to, run, walk or jog in that perspective. But I more like for like, if I can, I'd like more local tissue to come in rather than just pure free flaps, because that's always, it's an easier way, but the longer term revisions is what I end up doing a bit more.
And you still enjoy the free flaps sometimes?
Yeah, no, always. To be fair, I enjoy any operation, and particularly the ones that go well, but yeah, it's pretty standard practice. So over 2 years, I audited just my last 2 years, did about 70 free flaps, so about 35 a year, and that's a range, bone, recons, oral, tongue tumors. But that doesn't also count pedicle. Sometimes putting a pedicled pec major into a radiotherapy neck, tunneling it through, getting rid of scar, not knowing if it's a carotid you're about to hit or not, is more sometimes challenging.
Mills, I've got a question more about kind of innovation in this field, and that's the potential role of sentinel node biopsies for squamous cell. I mean, obviously, lots of us have heard about the potential role in melanoma, and there's some kind of preliminary data that suggests sentinel node is quite useful in squamous cell carcinomas. Do you mind just talking through your thoughts?
Yeah, I think that's a good question. And ultimately, so primary tumor, burden of regional nodal metastases. And if it's microscopic, how do you find it? And that's what we're talking about. I use sentinel node a lot for Merkel cells. So here, when we do have a Merkel cell, particularly in the head and neck, I will go after that sentinel node because I think you can influence the potential for radiotherapy to that donor basin. Then for SCCs cutaneous, there is no overwhelming evidence that you should go after an elective nodal dissection. So therefore, how can you target? So a good example, say if you've got a tumor on your lower lip, cutaneous SCC, but actually it goes into your muscle, technically it's a T3 tumor. Then the risk of nodal metastases to your either 1Bs or your neck can be up to about 20%, 15 to 20%. So therefore, should you then go and do a completion? For an oral cancer, if it's high enough grade and high enough risk factors, we probably would go and do a completion therapeutic nodal dissection. So the role of sentinel node, I would advocate. I'd probably try and bring it in a bit more. Most of our patients, and I think obviously in the scalp, knowing which site it goes to would help you greatly. Post-occipital as well, it's a problem. However, most of the ones we see, if they usually already present with macroscopic disease. So we're still dealing a lot with macroscopic disease. And I think certainly my training, my background research into sentinel node has probably made me more confident. And actually it's harder doing a sentinel node in the head and neck than it is a big neck dissection. Small holes, you know, trickier to find a node. It's always, so you've got to be careful of that. And I think in the right hands, that should be done.
Thank you.
So we have a question here from Gabrielle Edoué, or three, it's actually 4 questions, but is Gabrielle here? Would you like to come on and ask your questions?
Or is it Gabriel?
Maybe. And Dan Lazenby as well has a question. If you would like to come on.
Yeah, I'll promote them both.
An anonymous attendee has asked, is an Ipsy lateral neck dissection a contraindication to a supraclavicular flap?
It depends where. If you're just doing 1 to 3, if the supraclav pedicle's more in your sort of level 4 area. So if they've had an upper neck, no, don't mind. And if I'm doing a parotid and I take just say level 2, you can use your supraclav. Your golden triangle for your supraclav, as you know, is your clavicle, EJV, and border SCM.
Thanks.
Ah, we've got Dan here. Welcome, Dan. Where are you calling in from?
I am calling from Manchester in the UK.
Lovely.
Hello.
What's your question?
I just wondered, in terms of the patients that you have, obviously you cover probably quite a large geographical area, and your patients quite often seem to present late and often have used other homeopathic therapies and things. Do you find follow-up to be a challenge, or by the time you get to the point where they're having a large reconstructive procedure, are they sort of committed then? Are they in it for the long run and they're sort of in your hands?
Yes, a good question. It is a large area, as I demonstrated at the beginning, and it's much more hub and spoke. So specialist services, neurosurgery, plastic surgery are much more in Brisbane, the capital cities. And that's not discredit to any peripheral surgeons or colleagues that I have. So yes, we see them a bit more advanced, and they're probably coming a bit more frequent now because we've maybe built that service up as well. Once the patients do come, they have to be committed to undergo any big procedure, but we try and adapt. So if they are from really far away, usually I say they usually spend about a week in hospital just to make sure they're recovered. And usually then they spend a week in Brisbane, so they get an accommodation, an apartment somewhere, until I see them at 2 weeks in like our dressing clinic, make sure that donor site, everything is healed. Because if they are to return to their local facilities, this could be, you know, a cattle ranch in the middle of nowhere with not great either sanitation, it's very hot, humid, so dressings change a lot here. So that actually, Rebecca, that's true. Dressings here get really green quickly, so I have altered about those. So you've got to be ready. We use telehealth a fair bit. We were doing that before COVID as well. I think that helps. I touch base with them, and then usually I have good connections with, say, local radiation oncologists or surgeons who can then follow them up as well, commence their radiotherapy, and then I see them usually 4 months post-op. So usually at 4 weeks post-op, I touch base with them, whether it's in person or telehealth, and then 4 months post-op.
Thanks very much. Thanks for a great talk as well.
Thank you.
Thank you. So we probably need to wrap up fairly soon. One of the things James and I were just talking about is what next for you? Where are you going now on your journey, Mills?
Oh, that's a good question. I think each bit at a time. I probably want to just see, well, priority-wise, I want to see my kids grow up a bit more and be on that journey with them. I'm quite happy doing the work I do here. I've got a few research interests. So I've got a study in cutaneous scalp SCC. We're trying to make it multi-center recruiting. I've developed an app to try and monitor our flaps and capture all the images and progress with them to make it a bit more so suitable there. I'd like to do certainly more teaching, training. And yeah, I think just building that practice, keeping going, trying to do better the next day.
Thank you very much indeed.
If and when borders open, I'd love to come back to the UK, see my family, and visit Waitrose and have some proper tea. That'd be nice.
And come and visit Stoke Mandeville.
Yeah, of course. Yeah.
All right. Well, thank you very much. Thank you everyone for coming. It's been a fascinating evening. I've learned a lot.
SFI, it's been fascinating, Will. Thank you so much, and appreciate you getting up at 4 o'clock in the morning to give us this talk.
It's all right. It's a pleasure. Thank you. Thank you for having me.
Very much.